guess we are right on the hour, so we can slowly go ahead and get started. So welcome and thank you so much for joining us for this cardiac neck webinar. We have individuals from around the world joining us, and we're really excited to share that we have about 475 people that have registered from nearly 50 different countries. So welcome and thank you for believing in our vision of a world without neck. We want to mention that everyone is on mute, but we do have a Q&A tool where you can chat in your questions. There's also a chat box if you have thoughts or comments that you would like to share. This webinar is being recorded, and we hope to have the recording available within the next week or so on our website for anyone who needs to jump off early or might miss it. I want to thank our generous supporters who make this work possible, including the Patient-Centered Outcomes Research Institute, the Chan Zuckerberg Initiative, and the hundreds of individuals and organizations who support the NEC Society. So thank you. This webinar is being dedicated to baby Leyden, who you see on your screen there. Her mother, Melissa, is with us today, and she's going to be sharing her story in just a moment. So let's go ahead and get started. A few things I want to mention. We have a couple more webinars coming up this fall. We hope that you'll join us again on October 14th for our webinar on the long-term outcomes of NEC, and then again on November 18th for a presentation on the NEST trial. So hope to see you again then. And speaking of the long-term outcomes of NEC, we are actually doing a survey study right now, working to better understand how NEC affects families and adult NEC survivors years after their original NEC diagnosis. We have about 200 families that have participated in this so far, and we'd love to hear from more families. So if you're able to help us spread the word, that would be great. We plan to close the survey in mid-October, so that's available on our website. We're really thrilled to share that we are doing a charity run this year on December 12th and 13th, and we'll have more details coming soon. So we hope you'll consider joining us for that. And finally, want to get to the speakers that you will hear from today. For those I haven't had the pleasure of meeting, I'm Jen Canvasser. I'm the founder and the director of the NEC Society. My son Micah died from the disease when he was about a year old. You'll hear from Jonathan Kaufman, who he'll be serving as our MC for the day. He's serving as the NEC Society's strategic advisor. Melissa, as I mentioned, is going to be sharing her daughter Leyden's story, and she's also a board member. Stephen McElroy is a neonatologist at the University of Iowa, and he's going to be presenting on preemie NEC versus cardiac NEC. Caitlin will be presenting on the I'm going to have to look at my notes for a second just to make sure I get everyone's presentations right. So Caitlin's going to be presenting on the management of critical congenital heart disease. Patrick McNamara is also a neonatologist at the University of Iowa, and his presentation will focus on the neonatal hemodynamics in vulnerable bowel. And Amy Hare, who's a neonatologist at Texas Children's, will wrap up our presentations with a focus on feeding practices in infants with congenital heart disease. And then, of course, you're going to hear from Ravi, who will be helping to moderate our questions and discussion at the end. We hope to have at least 15 minutes. And he's a neonatologist at Emory University. So for anyone who's just joining us for the first time and isn't as familiar with the NEC Society, first, welcome. We're really thrilled to have you. We are a nonprofit organization that focuses on advancing NEC research, advocacy, and education by bringing together patient families, clinicians, researchers, and other diverse stakeholders who are really committed to improving outcomes for our most vulnerable infants. Just a quick disclosure before I hand this off to Melissa, we are not providing medical advice today, and everyone's viewpoints and presentations are independent from the NEC Society and our organization. So thank you so much again for joining us, and I'm going to hand it over to Melissa.
Great, thank you so much, Jen. It's an honor to be here, and I just want to say thank you to every person, regardless of your role, taking the time to invest in learning and hearing and expanding ways of thinking. From my daughter and my story, there's really nothing that means more. So I appreciate it, and thank you for allowing me to share the story of my daughter, Leyden. So my daughter, Leyden, was born in 2014. When I was pregnant, we were she was diagnosed with congenital heart disease. They suspected ASD, VSD, and possible coarctation of the aorta. We were in Boston at the time, and I had open heart surgery. I'd had an ASD repair at Boston Children's Hospital when I was young. So this was no strange, thing for us. Of course, it was scary, but the outlook was really good. She was born, and all hands were on deck. When she was born, there were 19 sets of eyes in the delivery room. Like, everyone was there. There were cardiologists for me, for my daughter Leyden, there was the NICU, there were the delivery staff, and I always laugh and say there were students from Harvard that were like, we're just here to observe. And I was like, welcome. So Leyden came into a full room of love and energy, and she really spread that love and energy throughout our time there. After a couple of weeks of observation, they decided that Leyden, we could go home. She was doing much better than they thought. The coarctation of the aorta did not present as an issue, and they wanted her to get a little bit bigger before doing the ASD and VSD repair. After a few weeks at home, Leyden wasn't growing. We were measuring her food. I was pumping. She was refusing her feeds. So I would pump, and then we would put formula in it, and actually vegetable oil in it as well, because they wanted to up the caloric intake. We measured all of her feeds. We weighed her multiple times a day, but she didn't grow at all over the course of those 3 weeks. And she became increasingly fussy. She was gassy, her belly was distended, and I called her doctor, I remember, on a Saturday, and I was like, something is wrong. And they said, you know what? We have a scheduled heart repair for Monday. At this point, they were going to do the full heart repair for the ASD and the VSD. They said, just come in on Saturday. We'll keep an eye, and we'll see, how she's doing. So this was a few weeks after that. So we went back in, and the morning of her scheduled surgery, one of her nurses observed blood in her stool, in her diaper. And I didn't know what this was. And it was kind of like a flurry. And they said it was possible neck watch, it was neck watch. And that instead of doing the full repair of the surgery, they were going to put a PA band to restrict the blood flow or constrict the blood flow. I apologize, I'm speaking as a mother here, not a medical professional. And that then we'd go home, she'd grow, and we'd come back. So they put the PA band on. It went really well, better than they expected. They said, you're going to go home again. You just need her to gain some weight. So this here was during that time. She still wasn't gaining weight. She was refusing her feeds. She was born 6 pounds, 2 ounces, and she was still 6 pounds, 2 ounces here. So they put the NG tube in to force the feeds, and Leyden refused them. She didn't take them. And after, this was in now May of 2014, we had been at Children's Hospital since March, and she was born in February. So we'd been there for quite a while, and they said, all right, let's do the full heart repair. So they did the full heart repair, and it went really well. They said everything was closed up, that it went better than they expected, and we were going to be going home. The next day, we gave Leyden a bottle, and at this point, they had her on neck watch previously for all the fussiness, but they ruled it as a milk allergy. So we gave her dairy-free formula. She took her whole bottle down. Everything looked great, and then her stomach began to expand. And it was at that point, yeah, you can go to the next slide. It was at that point that things got bad. So as you can see here, things deteriorated really quickly. It is still a nightmare. So we went from going home now. My daughter had 2 heart surgeries. She had the PA band and then the full heart repair. At this point, they said, we're going to go in and do an abdominal surgery. And they removed some dead intestine, and they sealed her abdomen back up. And they said, 2-week delay, you'll go back home. And a couple of days later, they came in and they said, this isn't going well. We're going to put her on ECMO. Now, I didn't know what ECMO was, and you can see here at this point what she looked like. So she was on ECMO, and there was just tubes everywhere. I never actually held her again after that time when I got to give her that bottle until the day of her last breath. At this point, this was in May of 2014. She had had her full heart repair on May 14th of 2014. 2 days later, she had an abdominal surgery. 2 days later, they did another abdominal surgery. They didn't find any more dead intestine, but they said they were going to leave her abdomen open. They took her off of ECMO, and you can see in this picture here, they said that she wouldn't live. And actually, before you go on to the next slide, she did live. She lived coming off of ECMO. I'll never forget sprinting back. It was June 3rd at this point of 2014. I can't remember what I did last week. I can remember every single day and date and moment of this. It was so intense. She lived. We put her on dialysis, and that transition went well. But about 2 weeks later, they had a family meeting. And despite, everything that I was fighting for and that everything that Leyden was fighting for, her brain was functioning. They kept checking for brain bleed. There was no brain bleed. Her heart was squeezing beautifully. She opened her eyes, even on max dosages of morphine. Anytime she heard my voice, she was fighting, but her body gave out on her. And on June 19th of 2014, my daughter Leyden lost her life. And the first time that she was actually diagnosed with necrotizing enterocolitis was on her death certificate. And so 6 years later, I'm sorry, I still live wondering, what if? And I don't get to know what if. I don't. But as Leyden's mom, I will fight and do anything I can to help another family from living with the what if. And so on behalf of Leyden and our whole family and the NEC Society, I just want to thank you for being here and for learning. And I can't tell you, we can't go back, but if we can help moving forward, I'm here to do it, and I'm honored to be a part of it. So thank you.
Melissa, thank you so much for sharing yours and Leyden's story. It's a powerful reminder of why we're all here and why this issue is so critical for us to bring people from all over the world, people thinking about this from lots of different angles together, so we can actually start to really make progress here. So thank you very much for opening up and sharing with us. I'm about to hand this off to Stephen from the University of Iowa. Before I do, just want to remind people, we've got the Q&A feature. So if you've got questions that are popping up, please go ahead and use it. We've got some time dedicated to the end of the webinar where we can start to go through those and open up to our panelists. So Melissa, thank you again for getting us going here. And Stephen, I'll turn it over to you.
All right, thanks, Jonathan. I'd like to thank the NEC Society for hosting this. I really want to thank Melissa for sharing her story. That was incredibly moving. And I want to thank all of you for taking some time out of your day to hear about cardiac NEC. I'm going to start this off by talking about preterm versus term NEC, and specifically cardiac NEC. Just a quick disclosures, in my laboratory, I do have collaborations with Evolve Biosystems and Defense and Therapeutics. I'm a consultant for Abbott Nutrition, and many of the drawings that you'll see in my talk were created with biorender.com. So most of you will kind of know this already, but I figured I should start off a little bit about defining NEC and what it is. We know that NEC is an acute inflammatory disease process of the bowel. It happens primarily to preterm infants, and in fact, those infants born at extremely low birth weights, about 7% of them will develop this disease. And despite knowing about NEC since the 1960s, NEC still has a really high death rate. The mortality rate is about 30%, and that's significant. It makes up about 10% of the deaths that we see yearly in neonatal intensive care units. NEC's incidence, it tends to be gestational dependent, and this is a graph that was published in 2012 in Pediatrics, and it shows two things. The first is the blue line, which shows the gestational age when these infants were born that went on to develop NEC, and you can see the smaller you are, the more likely you are to develop NEC. But for this talk, I want everybody to focus more on the red line, and the red line is what gestational age you were, or corrected gestational age you were when you developed NEC. And the majority of kids tend to develop this several weeks after they're born. They develop it somewhere between 26 to 34 weeks of age. But specifically for this talk, I want you to keep an eye out on the tail end of this graph where there's an uptick around term. And that's what we're going to talk a little bit about, the term neck and cardiac neck.
Steve, sorry to interrupt. Is it possible to come out of presenter mode?
Yep.
If that's easy to do, great. If not, keep on moving.
Yep. Is this better?
I think it's the same. That's okay. Keep cruising.
Keep going? Okay. All right. So how do we think neck happens? How do we really get from these happy babies that you can see on the left to, you know, within 24 hours, really sick babies that you can see on the right? And to talk about neck, we really first have to talk about the organ that it happens in, and that's the intestinal tract. Keep in mind that our intestine is the largest surface that we have as humans that interacts with the external environment. It's roughly several hundred times larger than our skin surface. And it really pulls this off because of all of the intricate folding that happens in the intestine. To the left, you can see an artistic rendering of what it would look like to swim down the middle of our small intestine. And you can see all those finger-like projections that are sticking out. To the right, you can see a drawing of what this would look like in cross-section. And there are a couple things to keep in mind. First of all is that the difference between the outside of us and the inside of us is 1 cell thick. So all that separates us as a host being from what's in our gut is just 1 cell, this epithelial layer that you can see. It also is holding back all of the microbiome as well as all of the substances that are present in our gut at any given time. So what do we think happens as far as neck? And this is one of the unknowns. Something happens to these kids that we're still not clear about that allows for weakening of the protective barrier of the intestine. Most of the microbes and other materials that are coming through our gut are contained in the mucus layer that sits on top of the epithelium. But whether it's hypoxia, inflammation, changes in the microbiome, a genetic predisposition, or something to do with what these babies are eating, or more likely a combination of these factors, something happens that allows the bacteria that are normally held at bay to get in closer to that epithelial surface. When that happens, two things kind of sort of happen simultaneously. The first is that these microbes trigger what we call pattern recognition receptors. And you may have heard of these, especially the toll-like receptors. These are receptors on the edges of these cells that they're looking out for things that shouldn't be there. Things like bacterial cell walls, flagella, things along those nature. And when they're triggered, they set off huge amounts of inflammation. The other thing that happens is that we have cells at the base of this small intestine called cells, and their job is to produce antimicrobial peptides and other materials which help keep the surface of the epithelium sterile. When those bacteria come in contact with the epithelium and that surface, they disrupt these cells, and that disruption also causes inflammation. And this inflammation then goes on to cause a loss of barrier integrity and allow the bacteria to actually invade into the tissue itself. When that happens, the body responds, and one of the big responses is an influx of white blood cells, which then cause free radicals and induce further inflammation. And we know that this happens because we see it on X-ray and we see it on the babies. And you can see pictures here of X-rays as well as gross pictures from a surgery and histology pictures of the gas that's produced by these bacteria. This gas is produced once bacteria are actually fermenting the tissue of the intestine itself. And that byproduct is what we call pneumatosis intestinalis. But really, so far, we've only talked about these small kids. And what we're here to talk about today is what happens to bigger kids, kids that are born at term. And as it turns out, about 10 to 20% of babies that develop neck are born at term and not preterm. And this is a different cohort of kids because the preterm infants have a really immature intestine. And one of the things that we think contributes to neck is this immature intestine's hyperactive response of inflammation to whatever's going on with this bacteria. Term kids don't have that same immaturity of the intestine. We get our information about these kids from really 3 large cohort studies. And what I really want you to pay attention to is the dates of these studies. So we've known about neck as a disease since really the 1960s. Cardiac neck and term neck is a really, really much newer disease phenomenon. And most of our information is coming over the last 10 to 15 years. The top two studies are very large cohort studies. Over the years you can see listed. The bottom one is a specific cohort study from C.S. Mott Children's Hospital in Michigan that was looking specifically at cardiac NEC. Now we know from these studies that babies that develop NEC at term tend to do it in addition to something else. So they don't seem to have NEC all by itself. They tend to be either growth restricted, they have sepsis or asphyxia. Most of them are formula fed. Some of them, especially in the newer studies, seem to be associated with neonatal abstinence syndrome. But today we're going to focus on the kids that have congenital heart disease. When you look at term infants, they typically present somewhere between 6 to 22 days of life, and the cardiac babies tend to be more consistently in that later range. As Melissa noted, one of the first things that we see with babies who develop NEC at term is that they have bloody stools and x-ray changes as their first signs, as opposed to the preterm infants that seem to have more signs that are consistent with a septic event, where they have apnea or vital sign changes or other things along those lines. Term infants tend to have their colon as their primary site of NEC, whereas preterm infants tend to have the small intestine as the primary site of NEC. And when we look specifically at babies who have congenital heart disease, there are some increased risk factors for these kids to develop NEC. One is if they're premature. If you're premature and have congenital heart disease, you're at a much higher risk of having NEC. But for the term infants, if you have impaired systemic perfusion, especially hypoplastic left heart syndrome or truncus arteriosus, these kids tend to have the highest risks of developing NEC. The other thing that's come out a lot is babies that are overfed, especially those with formula. And you can see in the bottom rates that kids with congenital heart disease have higher rates of mortality than preemies that have NEC alone. So in thinking about how this happens, one of our first studies that made us think that maybe cardiac NEC was a different physiology was this study in 2003, and they were looking at asphyxia in piglets. And what they found is when piglets were caused to have lower oxygen levels, their blood flow to their intestines was decreased. And that was found in the SMA, which is the superior mesenteric artery, and in the abdominal aorta. And the side effect of that was the intestines became necrotic in a way that was similar to what we see in necrotizing enterocolitis. But the first real key was this study by Dr. Carlo in 2007. And what this group did is they looked at babies that had congenital heart disease and NEC, and then matched them to babies who had congenital heart disease but didn't have NEC. And they looked at the blood flow through echocardiography. And what they found was that babies that had NEC and congenital heart disease tended to have what they call reversal of the abdominal aortic flow. And what I want you to think is when you look at this right picture of the intestine, you can see the red arterial vasculature to the gut. Normally that should be a constant flow going down to the tissue, but if you have diastolic reversal, it's much more like waves at the beach, where the flow goes down to the tissue but then is pulled back away from it, and that's then causing times where the tissue is not as well perfused as it should be. This has been followed up with two recent studies, actually this year, one which was looking at hypoplastic left heart syndrome infants who had had MRIs, and the other a retrospective cohort study. The MRI study was looking at babies who had this MRI, and they found that kids that had feeding intolerance or NEC compared to those that didn't seemed to have lower aortic blood flows than the kids who did not have NEC or feeding intolerance. And in the retrospective cohort study, what they found is that babies who had cardiac diagnoses in addition to NEC, and it was both patent ductus arteriosus or congenital heart disease, seemed to have higher levels of necrosis and intraoperative bacteria compared to preterm NEC babies who did not have heart diseases. And this suggests that there's an increased amount of necrosis if you have a heart disease. And again, thinking that there's a problem with blood flow to these tissue. And we think that this reduced blood flow may predispose the infants to secondary injury. And remember again, the intestine is a very, very vascular organ. You can see several pictures here. The top left picture is an intraoperative picture just showing the arcades of blood flow going to the gut. The picture to the right is actually a cast of all of the blood vessels in the gut, and you can see the vast amount of blood vasculature that's there. So if you have a time where blood flow is decreased to the gut, that may actually be causing the initial injury that then leads to necrotizing enterocolitis. Thanks for listening. I will stop here and turn this over to talk a little bit more about the heart and blood flow, and we'll be happy to take any questions people have at the end.
Thank you very much, Stephen. It was great. Really appreciate all of the rich content. We're going to turn it over to Caitlin from Nationwide Children's to walk us through the next portion of this. Caitlin, when you're ready.
Thanks very much, Jonathan. Oops. Here we go.
Caitlin, if you want to turn your video on too so we can see you, that'd be great.
Of course. All right, great. Hi, everybody. Thanks so much. I'm very honored to have the opportunity to speak with you guys today. In my section, we'll review the types of critical congenital heart disease that is most associated with greater risk of necrotizing enterocolitis. So at the end of this section, I hope that you guys understand the meaning of critical congenital heart disease and the types commonly associated with poor systemic blood flow. Hopefully you'll be able to describe some left-sided obstructive heart lesions and the mechanisms by which systemic blood delivery is impaired, understand the concept of pulmonary overcirculation and systemic seal and which types of congenital heart disease may be at risk, and review the features of hypoplastic left heart syndrome, HLHS, that place those patients at unique risk for NEC. I have nothing to disclose. And I know that not everybody in the audience spends their days thinking about hearts and cardiac physiology. So we'll begin with a very brief refresher of normal cardiac anatomy and blood flow. So initially, deoxygenated blood returns from the body via the superior and inferior vena cava, enters the right atrium, moves through the tricuspid valve into the right ventricle, moves through the pulmonary valve, and into the main and branch pulmonary arteries. The two branch pulmonary arteries bring blood to the lungs. The blood flow through the right-sided heart chambers will provide what is known as the pulmonary blood flow, also known as QP. Once the blood returns from the lungs, it returns via the four pulmonary veins, and then enters the left atrium, moves through the mitral valve into the left ventricle. The left ventricle pumps through the aortic valve into the aorta and out to the body. The blood through the left side of the heart chambers provide blood flow to the systemic circulation, also known as QS. In a normal heart, the amount of blood flow going to the lungs, QP, is equal to the amount of blood flow going to the body, QS. However, in congenital heart disease, that is rarely the case. So what is congenital heart disease? So congenital heart disease can be considered any structural heart malformation that is present from birth. Critical congenital heart disease is a distinction in that it's congenital heart disease that requires surgery or other intervention in the first year of life. A particularly severe form of critical congenital heart disease is a ductal-dependent heart lesion. And so a ductal-dependent heart lesion requires that the patent ductus arteriosus, the PDA, remain open to help supply blood to the pulmonary or systemic circulation. And so if you look at the image over to the side of the screen, you'll see that the blue deoxygenated blood is unable to move through this atretic pulmonary valve. And so that deoxygenated blood has to enter to the left side of the heart, mix with the oxygenated blood, and go out through the aorta. The only blood that's presented to the lungs is that which flows through the PDA. And this is just an example of a ductal-dependent heart lesion. There are many others. Babies who have ductal-dependent heart lesions require a medication called prostaglandin to keep the PDA opened after birth. And patients with ductal-dependent heart lesions will definitely require surgery as a neonate to fix their heart, usually within the first few days up to a week of life. An important point is that across multiple studies, ductal-dependent congenital heart disease has been associated with an increased risk of necrotizing enterocolitis compared to non-ductal dependent. But those are not the only types of congenital heart disease that are at risk for NEC. So there have been some studies, including one published back in 2000 by McElhenney, which has attempted to characterize other anatomical risk factors. Stephen made reference to the fact that hypoplastic left heart and truncus arteriosus are two heart anatomies that are associated with an increased risk of necrotizing enterocolitis. There are some others that have been shown, including left-sided obstruction, like coarctation of the aorta, also any single ventricle heart disease with or without arch obstruction, and other low systemic cardiac output states and shock. A more recent study published by Lau et al. In the Journal of Pediatric Surgery from 2008 looked at 10 years of data out of Texas Children's and looked at, there was a total of 61 patients who had both congenital heart disease and developed necrotizing enterocolitis. And this table here shows that, 16 of these 61, so roughly 25%, had a diagnosis of hypoplastic left heart syndrome. But if you scan through the remainder of this table, you see that it's not just hypoplax and truncus arteriosus. There's an array, there's really a wide variety of congenital heart lesions that went on, that the patients went on to develop necrotizing enterocolitis. And so this really emphasizes that there are many patients with CHD that are at risk for NEC. And so what problems may reduce systemic circulation in patients with congenital heart disease? Stephen McElroy did a really nice job of showing that decreased oxygenated blood delivery to the gut seems to be associated with a higher risk of necrotizing enterocolitis. And I think rather than memorizing specific congenital heart lesions, it's nice to break it down in terms of some key anatomic problems, sort of big buckets or big categories of anatomic problems that can lead to decreased gut perfusion. And so one big category would be a mechanical obstruction. Just like the boulder in the middle of the road is obstructing flow of traffic, congenital heart disease that leads to mechanical obstruction obstructs the blood flow to the body and the gut. There are also problems with aberrant flow, specifically too much pulmonary blood flow and not enough systemic blood flow. And like this picture here showing, a defect in the wall of the dam, allowing more flow down a path of least resistance, there are particular congenital heart anatomies that allow that to happen. Way too much blood flow towards the lungs, which is typically the path of least resistance versus the body. So what does this mean? So there is a big category of congenital heart disease called left-sided obstructive congenital heart lesions, and those are the ones that cause mechanical obstruction. Specifically, aortic valve stenosis, in which the aortic valve is stenotic and blood has trouble moving through. Mitral valve stenosis, likewise, causes that mechanical obstruction to blood flow. Coarctation of the aorta, when the aorta narrows down, typically just beyond the insertion of the ductus, causing obstruction of blood flow. And finally, interrupted aortic arch, which is a rare congenital heart lesion, but can almost be thought of as a very severe extreme of coarctation in which there's actually an interruption between the ascending and descending aorta. And all left-sided obstructive lesions present similarly. They present with shock, tachycardia, tachypnea, poor perfusion. Depending upon the severity of the mechanical obstruction, these lesions may be ductal dependent and or require neonatal surgery for correction. And again, severe obstruction decreases gut perfusion and raises the risk for NEC. And then we've got our aberrant flow. So if there's too much pulmonary blood flow and not enough systemic, this can be caused by two big buckets of congenital heart lesions. So this could be caused by congenital heart disease characterized as a left to right shunting lesion, or congenital heart disease characterized as a mixing lesion. And so what do I mean by a left to right shunt? These are all examples of left to right shunting lesions. Ventricular septal defect, where there's a hole between a hole in the wall between the two ventricles. atrial septal defect, a hole in the wall between the two atria, atrial ventricular canal defects, also known as AV septal defects, in which there's a primum ASD and a large inlet VSD and usually some additional valve abnormality. PDAs are also considered left to right shunts. And again, this is when the ductus arteriosus remains open after birth, permitting blood to flow directly from the aorta into the pulmonary arteries. The last left to right shunt is the AP window, which is a very rare type of congenital heart disease at high risk for necrotizing enterocolitis, in which there's a hole between the aorta and the main pulmonary artery, and the blood can flow directly from the aorta into the pulmonary artery and not as much proceed out to the body. So the key concept here is that blood will always move from a higher pressure chamber to a lower pressure chamber. Therefore, always move left to right, unless there's some other problem that prevents it from doing so. So again, it will always move from left ventricle to right ventricle, from left atrium to right atrium, from aorta to main pulmonary artery. Congenital heart disease that's characterized by a left to right shunt leads to this extra blood flow to the lungs, or an increased QP, and decreased blood flow to the body, decreased QS. The word for this clinically is pulmonary overcirculation and a relative decreased systemic output. Babies with pulmonary overcirculation will show signs of tachypnea, poor feeding, failure to thrive. In severe cases where the amount of pulmonary blood flow is much greater than the amount of systemic blood flow, this can lead to the type of gut hypoperfusion that Stephen had mentioned and increase the risk for NEC. In addition, this extra blood flow to the lungs can lead to irreversible pulmonary vascular changes over time and cause pulmonary hypertension if not fixed. And patients with left to right shunting lesions may require congenital heart surgery based upon symptoms and overall size of the shunt and likelihood of spontaneous closure of the defect. So we talked about left to right shunting lesions as a problem with aberrant flow. There are also mixing lesions in which the QP, or the flow to the lungs, is much greater than the flow to the body. And so mixing lesions, I think, are a little hard to wrap your head around when you're sort of memorizing specific cardiac anatomies. But I like this diagram because it summarizes it pretty nicely. In a mixing lesion, you have all of your pulmonary venous return, all of the oxygenated blood, the red blood, and all of the systemic venous return, the deoxygenated blood or the blue blood. And there's complete mixing with those particular types of congenital heart lesions. So examples of mixing lesions include our single ventricle congenital heart disease, like hypoplastic left heart syndrome, in which an underdeveloped left ventricle it doesn't have enough volume to pump blood out to the body. Typically, there's mitral valve stenosis or atresia and aortic valve stenosis and atresia, and there's complete mixing of the oxygenated and deoxygenated blood in the right ventricle. Tricuspid atresia, there is an imperforate tricuspid valve, so it's more like a plate-like amount of tissue there. The blood has to get over to the left side of the heart where there's complete mixing, okay? So mixing lesions, single ventricles are mixing lesions. But you don't have to be a single ventricle to be a mixing lesion. Truncus arteriosus is a congenital heart defect in which all of the blood is mixed through a single outflow tract. So the aorta and the main pulmonary artery come off a single outflow tract and then divide, but there's complete mixing at the level of the outflow tracts. And finally, total anomalous pulmonary venous return, or TAPVR, is a problem in which the 4 pulmonary veins fail to insert onto the back of the left atrium and instead have aberrant drainage, which leads all of that oxygenated blood back into the systemic venous return. So there's complete mixing at either the inferior vena cava or in the innominate vein back into the SVC. All right, presentation is variable for mixing lesions and depends on whether there's too much or too little pulmonary blood flow. Rarely they're well balanced. If there's too much, they'll have signs of pulmonary overcirculation. If there's way too much, they're at risk for gut hypoperfusion and NEC. So why do patients with hypoplastic left heart seem to have increased risk of NEC? In short, they have potential for both problems: left-sided obstruction at the atretic aortic valve or the very small aorta, and a mixing lesion with the potential for far more blood flow to the lungs versus the body. So two problems likely relating to the greater risk of NEC that we see with this specific heart anatomy. So we've covered a lot, but I want to thank you guys for allowing me to speak to you today, and I will answer questions at the end. Thanks very much.
Caitlin, thank you so much. Absolutely fascinating and so informative. Really appreciate you taking the time. Great. We are going to transition now to Patrick over at the University of Iowa, who's going to talk about neonatal hemodynamics and the vulnerable bowel. Patrick, if you're able to start your video and screen share, we can get rolling. Patrick, if you're there, you're on mute and your video is off.
Okay, I'm off mute. Can you hear me?
Yep, great. And go ahead and start your screen share and we can get rolling. Thanks, Patrick.
Right. Okay, perfect. I would really like to thank the NEC Society for hosting this webinar on a topic. To be honest, I've given a lot of talks about cardiovascular stuff and have never been asked to talk about NEC. So it's an absolute privilege and honor to try and share some particular thoughts. I have no relevant disclosures for this particular talk. So I think Steve and Catherine really have led this up very, very nicely to me to try to take this now in another direction. So you've heard about congenital heart disease and its relationship to necrotizing enterocolitis. However, there are many other cardiovascular antecedents, and unlike infants where it is very obvious when you know that you have congenital heart disease, many of the conditions that we take care of in the NICU, ranging from abnormalities of heart function to blood flow, are perhaps not always so obvious, which creates a much more difficult dilemma in terms of identifying and predicting who are the patients at greatest risk of necrotizing enterocolitis. Now, what's common to everything that you're going to hear today, this is all about fuel. Okay, the bowel needs fuel. It needs oxygen, it needs glucose, and whether you're an athlete or whether you're a car that runs out of gas, good things don't happen. Okay, when you don't have fuel. Now, it's not all doom or gloom. This is a recent paper from the INEO network, which is a network of 12 countries who pool population-based data. But what was particularly interesting, and Steve talked about the composite of prematurity and congenital heart disease, data from the INEO neonatal network, which includes Canadian data, suggests that actually we may have made some progress. In these particular countries, the rates of NEC was comparable in infants with severe congenital heart disease to those without congenital heart disease. So I'm not going to focus very much on congenital heart disease. I want to focus on something more controversial, which is the challenge of providing cardiovascular care in the NICU and anticipating conditions that place those babies at greater risk of bowel injury. The problem in the NICU is we do not have good, reliable metrics. And a result of poorly reliable metrics, there's a lot of confusion, there are a lot of dogma, perceptions, misperceptions. And we're going to talk about two assumptions that underpin neonatal hemodynamic care. First assumption, that it's all about blood pressure, that normal blood pressure means that you have optimal bowel perfusion. And secondly, Catherine spoke about the ductus. The ductus has become a very controversial topic in neonatology, and we've gone from one extreme viewpoint to another extreme viewpoint, and we think we need to create some balance. So to understand the preterm cardiovascular system, I think there's important concepts that you need to understand. Developmentally, the immature heart has got much less muscle, which leaves those infants vulnerable to heart dysfunction, particularly when they're subjected to elevated afterload. And that occurs in infants with pulmonary hypertension, immediately after birth, or when you close the ductus. In addition, the shunts may play an important modulator role, and we don't necessarily know when our drugs are doing the right job. So in most countries across the world, unfortunately, Our metric of cardiovascular well-being is mean arterial pressure. And in many countries, people practice in a very algorithmic manner, which does not take into account diagnostic precision or the variance that may occur physiologically in these patients. And not surprisingly, when you look at studies that have looked at the relationship between treatment of low blood pressure based on this metric, the data suggests that treated babies, at least if you're looking at mortality or adverse neurodevelopmental outcome, don't do very well. And this has prompted some experts to say blood pressure is not relevant. I think this is probably an extreme viewpoint, and we need to think of this in a more comprehensive manner. Just to share with you the complexities of things that we do on a day-to-day basis, I want to share with you briefly a case. Happened about a year ago. This was a preterm infant, 28 weeks gestation, who had low blood pressure. The infant received hydrocortisone, which led to normalization of the blood pressure. However, the infant developed progressive metabolic acidosis and elevated lactate. And because we fortunately in our program, we have the ability in the NICU to perform longitudinal echocardiography as neonatologists to provide this hand precision. What you can see in the picture on the top, this infant had a right ventricle that was not contracting. His cardiac output was about a quarter of what it should be, yet his blood pressure was normal, which really creates a challenge for people. If we want to optimize perfusion to organs, we need to have the right information available to us. So where does this concept of low blood pressure and gestational age come from? It comes from nowhere. In 1992, a consensus of pediatricians in the UK said, we have no idea what is a normal metric of well-being in premature or term babies. The mean blood pressure seems to equate with the gestational age. This may be a useful guide. From this, the problem is people have elevated this measurement to almost godly status that must be fixed immediately and at all costs. Plus, as well, it has forced us to go down a vasopressor approach to these babies. So does blood pressure predict cardiac output? Absolutely not. There are babies with normal blood flow who have low blood pressure. There are babies with normal blood pressure who have low cardiac output. So we need a degree of sophistication of monitoring of the cardiovascular system if we are to try and enhance bowel perfusion. What about drugs? Here's a very nice study looking at the unpredictability of drugs. Dopamine is the drug that probably 99% of neonatologists will use in the situation of low blood pressure. There are some babies, like group A, in whom the blood pressure goes up, the cardiac output goes up. There are other babies who have an even more potent increase in their blood pressure due to marked systemic vasoconstriction that leads to a reduction in cardiac output and a reduction in bowel perfusion. What was most interesting was this data challenged contemporary thinking that higher doses of dopamine led to more vasoconstriction. These babies actually had a lower dose of dopamine. So non-judicious use of vasopressors may compromise bowel perfusion. And this is very problematic because the neonatologist does not always have this information available to them. Now, Catherine talked about the ductus arteriosus, highly controversial. But if we go back into the early days of neonatology, even in those days, the presence of a large ductus and its association with mortality was very, very strong in the setting of necrotizing enterocolitis. This data by Stephen Polder demonstrated that your mortality from NEC was 60% if the NEC occurred before you ligated the duct versus none after the ductus was closed. Not surprising, we've already gone through the physiology. If you have a large left to right shunt, as you see on the schematic on the left-hand side, postductal perfusion, bowel perfusion is compromised. The problem is when we start to think about how we manage these babies, if you restrict the fluid to try to decrease pulmonary blood flow, you're now further restricting fluid to the bowel. If you give drugs like dopamine to increase the blood pressure, you're having another added negative impact on the bowel. The problem, we don't have a lot of science to prove these facts. What we do know is that PDA impairs oxygenation of the bowel. We also know that if you feed babies with PDAs or large PDAs, their cardiac output or their bowel perfusion does not increase to support the nutritional needs of these patients. We know from the early days, this is George Cassidy's study, that surgical ligation on day 7 of life in this patient population was associated with a profound reduction in NEC, plus from Ron Kleiman's early meta-analysis that earlier intervention led to a significant reduction. It'll prevent NEC. During the intervening period, however, the numbers of babies who receive both medical and surgical therapy for the ductus arteriosus have fallen. So why has that happened? It's happened in part because we've done a lot of trials, and when you look at the outcomes from these trials, treatment of the PDA does not necessarily reduce important neonatal outcomes, one of which is NEC. The fundamental question is, when you put together 67 trials like this, have we actually managed the patients that we're interested in? So if we look at the meta-analysis from a very objective perspective, we probably have not done the right type of studies. More than 40% of trials did not even have an echo diagnosis of PDA. Pretty much 100% of the trials did not standardize how hemodynamic significance was adjudicated. So it's very possible that many babies with small shunts were treated. Many babies with pulmonary hypertension who need their PDA were treated. Two other important factors: more than 60% of patients in the control group received medical therapy. And to me, one of the unanswered questions is, are these trials relevant today? Many of them, more than half of them, were done over 15 years ago. We have moved a lot in our practice. One of the most important concepts, however, is how was the problem adjudicated? And in the vast majority where echo was used, people looked at just the diameter of the ductus. And the problem with this approach is that depending on the type or shape of PDA that you have, the imaging plane may either underestimate or overestimate the size of the vessel, which is why over 10 years ago, we proposed that if you really want to identify problematic PDAs, you need to look in a much more comprehensive manner. You need to recognize that there are situations in which you need your duct from situations in which it's not helpful. So is it important? I absolutely think that the ductus is important. Here's a population-based study from Denmark, from Anna Selma's group that I was fortunate to help with. The presence of a large PDA on day 3 of life was associated with a 2-fold increase in mortality, a 6-fold increase in bad brain bleeding, and a 5-fold increase in necrotizing enterocolitis. The American Academy of Pediatrics suggests that the ductus is not a problem in the first week of life. Here's a baby who is 6 hours old. Even by 6 hours, this infant had QPQS of 3:1, with profound flow reversal in the postductal arch, with flow reversal to the bowel. And Steve has already pointed out why flow reversal postductally is not a good thing in terms of the bowel. Here's the data from a study we conducted about 5 years ago, looking at an untreated population in the first week of life. And what you can see, babies with a larger shunt have increased risk of excessive pulmonary blood flow based on these measurements, and as early as day 2 of life, have major compromise to bowel perfusion. The problem, without early longitudinal echo, our clinical metrics do not help us identify these patients. Ron Kleiman published a very interesting paper recently. This was a center where they used prophylactic indomethacin to treat the PDA, prevent brain hemorrhage, and then they stopped doing that. And what they found was that in the second epoch, when you would expect intensive care to be better, as we evolve, things should get better, the incidence of refractory hypotension in the first week of life was much higher. And when they looked at what drove this, the presence of a large PDA was the major driver of low blood pressure and cardiovascular instability, which begs the question, are we treating the right patients in these trials? The most recent trial of PDA Tolerate suggests that early treatment may not be beneficial. However, this is a follow-up study from Melissa Leibovitz, which actually demonstrated that 137 patients who were approached to be randomized, the physicians did not have equipoise. Who were those 137 patients? Well, these babies were younger, sicker, less likely to have antenatal steroids, but interestingly, these babies were treated and treated early in the first week of life. Their outcomes in terms of mortality, chronic lung disease, were superior to any of the patients in the trials. So there are likely to be populations of risk. The problem is, are our therapies harmful? One of the concerns with drugs like indomethacin is that it is a vasoconstrictor. And how does this balance between recovery of perfusion, but the vasoconstricting effects of the drug, how do they interact with each other? The best data available to me is the Dahlberg study from 2005 from the Israeli network, which had close to 10,000 patients. When they looked at their population, the odds ratio for the association between PDA and NEC was significantly reduced after the administration of indomethacin. And they did not find a significant increase in bowel perforation in this population, suggesting that NEC and PDA is a much stronger association than the association of a bowel complication from the drug itself. So finally, what about the relationship to feeds? This is a good segue for Amy. You heard Steve speak about SMA flow. Again, tale of caution. From the data that have been done from primate studies and human studies, it's pretty compelling that bowel perfusion is compromised and you do not see the postprandial increase in perfusion, but the measurement itself has limitations. Personally, I think we need to do better studies and better longitudinal studies. So what about how can we move forward? Well, we have a neonatal hemodynamics program here at the University of Iowa. We do 95% of all the echo scans in the NICU, have got very clear, comprehensive protocols to manage these babies. And when we arrived here 2 years ago, we introduced a comprehensive screening program whereby all preterm babies in the first 12 to 18 hours of life had a comprehensive assessment. And based on the physiology, a physiology-specific therapy was provided. Heart dysfunction, we would provide some dobutamine. If they had a moderate to large PDA, we treated them with Tylenol. If they had congenital heart disease, we referred to cardiology. What's happened hemodynamically here in the last 2 years? Well, we rarely use dopamine in the first week of life. The incidence has gone down by 90%. Our incidence of PDA ligation has, in the tiny babies who are at greatest risk of NEC, has been halved. Our rates of IVH in the most vulnerable patients has also fallen. But something that surprised me, and again, I cannot say that this is 100% due to whether it's PDA treatment, avoidance of dopamine, but our NEC rates have fallen to the lowest ever. So in summary, bowel perfusion is an important contributor to ischemic colitis, but it's difficult to identify in the NICU. We need to have better ways to adjudicate, is the patient hemodynamically compromised or not? Unfortunately, in many places, an imprecise, indiscriminatory approach to deranged hemodynamics continues to be used. And we need to study this, and we need to do better. Enhanced diagnostic precision, I think, is the way to move forward. And physiology-based treatment may help us by enhancing our cardiovascular care. Hopefully, we can further enhance our bowel perfusion and prevent this terrible morbidity. Thank you very much.
Patrick, thank you so much. Really expanding the conversation we're able to have here, and it's really just absolutely wonderful. So thank you very much for taking the time. That is a great segue into Amy from Texas Children's, who's already got her screen up and running. Amy, I'll let you take it away.
Wonderful. Thank you very much. I'm very excited to be here today to talk about feeding practices in infants with congenital heart disease. I first want to talk about, I am a neonatologist. I'm not a cardiologist. I'm not a cardiac intensivist, but I do have a special interest in neonatal nutrition. And so our program at Texas Children's not only goes to the NICU, but we are also very fortunate to collaborate with our cardiac intensivists as well as cardiologists to improve nutrition, not just for our NICU babies, but for our babies with congenital heart disease. I do have 2 disclosures. I received research support from Prolacta Bioscience for 2 studies, and my center is part of the SMOF randomized trial by Fresenius Kabi. One extra disclosure is I am a native Texan, so if you hear a y'all in there, that is because I'm from Texas. So our objectives, and by the way, that joke is way better when we're in person. So this is the best we can do with Zoom. So I'm thankful we're at least able to have webinars. But we're going to discuss current feeding practices and talk about some of the literature regarding these feeding practices and identify knowledge gaps. We'll talk about the use of human milk for infants and the benefits, as well as review recent studies of human milk use in infants with congenital heart disease. And a lot of what we know, so first of all, the 2 things. One, neonatology and I think cardiac surgery haven't been around as long as some of our other medical disciplines. So I do think we're finally catching up in research and studies, especially in the nutrition world. But I think what we do know about neonatal nutrition, we have started to extrapolate to other populations because there aren't studies. And so I feel like some of this is happening in infants with congenital heart disease. And if you look at the data, there's not that much, and there's a lack of consensus on how we should feed these infants pre and post-operatively. And as you've heard from the talks before me, obviously, I think it's very dependent on the physiology of the infant and using targeted echo, looking at the real-time physiology of the infant and blood flow to the gut. But in general, there's no prospective studies and very few studies on human milk. And you'll see here on the right, I actually Google imaged enteral feeding protocol pictures for congenital heart disease, just to show you that there's quite a variety on the internet. But we do know that standardization of care at our centers with feeding protocols can improve outcomes. This has been proven in the NICU. The problem with protocols is that there's always an out for the provider, depending on their comfort level and experience, to kind of change how they're feeding an infant. And it also makes it difficult to do multi-center studies. And so I thought this was interesting that the European Society for Pediatric and Neonatal Intensive Care did a survey. And what they found regarding enteral feeding practices in infants with congenital heart disease, they found wide variations exist in the nutritional care between European PICUs, which reflects the absence of local protocols and scientific society-endorsed guidelines. And I'll tell you a little bit more later about what the U.S. is doing to change this. I also wanted to show you, just so that you don't think just so you believe me, that there is a lack of data out there, but just on PubMed, you can see that it's only been the last few years where there's been quite a rise in publications, which is good because we need guidance on how to feed infants with congenital heart disease. This is just an example of 5 studies that we ended up using from a meta-analysis, systemic review of meta-analysis that came from our unit, and we were looking at preoperative feeds and ductal-dependent cardiac disease. And I do want to take a moment I hope I don't embarrass Dr. Kataria Hale, but Jasmeet really spearheaded during her fellowship, which she just ended, the kind of nutritional improvements in the cardiac ICU, and she also really spearheaded a lot of these publications, and some of these slides I dedicate to her. So from the systematic review and meta-analysis, we really just found that most of the studies, again, are retrospective. Most of the studies focus on post-operative feeding and hospital outcomes, but what about preoperative feeding? And what do we do with that? And so further studies are needed. And I don't think I need to go through this, so this is great. I can kind of skip a slide, but I think all the previous presenters have kind of shown you why we're worried to feed these infants with congenital heart disease, especially critical congenital heart disease. And I think I was most impressed by Dr. McElroy's picture of the cast of the blood system to the mesentery and to the gut. It's quite vascular, and you can see how hyperperfusion would affect the gut. And so this is kind of coming a little bit from neonatal literature, but we're afraid to feed babies with congenital heart disease. We don't like necrotizing enterocolitis. That's why we're all here, to build a world without NEC. But the risk of not feeding on the flip side is that you get atrophy of intestinal mucosa, you can have abnormal gut permeability, delayed development of the microbiota, you can have intestinal cell wall barrier issues, and motility problems. And so where does this leave us? Well, with premature infants, we have found that using mother's milk and human milk for early feedings does impact our long-term outcomes for these babies. And so we know the American Academy of Pediatrics recommends that that breast milk is the best source of nutrition when it's safe and available. And for preterm infants, we actually supplement mother's milk with donor human milk. But with breast milk, we know in preemies, there's decreased infection, decreased NEC, decreased chronic lung disease, and improved neurodevelopmental outcomes. And we're also starting to learn through some of our studies that giving mother's milk early on helps develop this intestinal microbiota. And the problem is that, yes, we'd like to give early feedings with human milk, but even despite this, even babies that are fed human milk do develop NEC. So we do recognize it's a multifactorial disease, but what are some things that we can do to kind of alter the risk factors for cardiac babies? And I just love this slide because it's a minimalistic approach to what is in breast milk. Breast milk's not man-made. Comes from nature. It has many immune factors and many components that we can't even test for. But some of the thoughts about how breast milk protects the gut, you can see here through anti-inflammatory factors, growth factors, enzymes, etc. And so what's our knowledge gap? So is it safe to feed neonates with ductal-dependent congenital heart disease preoperatively? And the reason I say ductal-dependent, I think Caitlin went very good through this. It's those babies that initially on in their course are most critical and are most challenged to take care of, the ones that have early surgery. And so do the benefits of feeding outweigh the risk? And does the type of cardiac lesion matter? And then what about the use of human milk? Are the benefits we see in premature infants the same for our cardiac infants? And will we see improved outcomes? And I'm gonna throw in too also, what's the utility of the use of donor human milk for our congenital heart disease population? So we wanted to answer this question here at our center. We looked over a 6-year period at 546 infants. And what we found, we were trying to see if we fed infants preoperatively, what was their risk of NEC? Well, our overall cohort, thank goodness, we had a low NEC rate of 3.3%. But of those infants, and studying that, we found that unfortified human milk diet was associated with a significantly lower risk of preoperative NEC. And some of these infants they mainly received mother's milk, but about 7% did receive some donor milk. And so kind of moving forward, I just wanted to quickly go over some of the challenges. So yeah, it's easy, feed babies human milk. And we all know it's much more difficult than that. And especially, like I said, even if you feed a baby human milk, there are additional risk factors for NEC. But what we've learned over the last 10 years, and as I said, it's been great to collaborate with our cardiology and intensivist colleagues. But simple things, if moms are gonna pump, you need to have a refrigerator nearby. We actually, 10 years ago, didn't have a dedicated milk fridge. We used to have limited lactation support, and now we have an actual lactation consultant that goes directly to our infant cardiac babies, as well as we've had increased education to providers and caregivers. We still have a fear of NEC, and I don't think that's going to go away until we get rid of NEC, but we're consciously aware of it, but trying to improve care, not just to prevent it, but ways that we can feed babies and try to avoid the risk of NEC. We have since developed, twice now, we've had multidisciplinary groups come together to come up with evidence-based protocols. And hopefully over the next 2 years, there'll be some more literature to guide practice. And also just realizing more, and even as a neonatal nutrition expert, I'm realizing nutrition does matter, but initially when these babies come back from surgery, obviously there are other things that are more important initially than nutrition, but then how do we start early nutrition after that? And so this is just an example. I'm not going to go through it, but this was Jasmeet's fellowship project. And we were trying to increase the use of mother's own milk for our cardiac babies. And we started with oral care. So oral care is colostrum. This is the first pump milk that mom gets, sometimes just drops. But what Jasmeet did is she developed an education program. She would give a pamphlet to these mothers in the clinic before, like, we knew they were going to have a baby with critical congenital heart disease, to talk about the importance of pumping. And then we had these oral care kits. And so moms were able to pump early, and these drops of milk were able to be given inside the baby's cheeks once they received the milk. And our reason for doing this is studies have shown that if mothers pump early and get colostrum, they may have an overall supply, longer term supply. And this is under review currently, but this is just showing you that before our protocol development with the oral care and this newer feeding protocol, we had a 42% formula use. And post protocol now, we have absolutely no formula use. And what's interesting is that pre and post protocol, both groups received about 7% donor milk. So we actually were able to increase our use of mother's milk. And so I would say if there's one intervention you can do in your unit, it would be to increase the use of breast milk and try to focus on ways to help moms with that. Again, that doesn't get rid of all the risk factors, but it's a huge step forward. And I know this weekend at the American Academy of Pediatrics, there's special sessions focusing on neonatal cardiac disease. And I know the Neonatal Heart Society, in conjunction with other societies, is working on a neonatal, they call it the 3C, or Cardiac Care Collaborative. And so I think that's very exciting that guidelines hopefully are going to be developed from this so that we can all improve care of nutrition and feeding for our congenital heart babies. And then there are research studies pending. I saw that there's an abstract at the AAP showing donor milk use given to cardiac babies improve feeding tolerance, so that's reassuring. And then there is an ongoing nutrition study. Once babies have their surgery and they get to full feeds, we have to figure out ways to give them additional calories. And right now, we really only have formula alternatives. And so there is a new product that's being studied that is a donor human milk-derived term fortifier designed specifically for these cardiac babies. So I think we have a lot to look forward to upcoming. I would like to acknowledge my team. I couldn't do this without them. My neonatal cardiac nutrition team, my neonatal dietitians, you can see my other collaborators, my research group, and of course our milk banks at Texas Children's and our lactation department. Also thankful to be here today. I am a scientific advisor for the NEC Society, and we want a world without NEC, and so we are spearheading efforts to get there. And with that, I'll end my talk. We'll take questions.
Amy, thank you so much. Very, very excited about where all of this is going. And to all of the presenters, what a phenomenal caliber of brains we've got in the room here with us today. So thank you all for sharing your expertise and your time. I'm going to invite all of our panelists to turn their videos back on so that we can see everybody. And Amy, you can actually go ahead and stop screen share so we can make sure we see all the panelists. And I'd like to introduce Ravi from Emory University, who's going to moderate a Q&A for us. So Ravi, I'll leave it with you.
Well, thanks, Jonathan. And we have several questions here to start. And I'd like to just thank Melissa for sharing Leyden's story. I think it puts into focus of really why we're here today to better understand this. The first question, and maybe this is to Patrick and then others can add in, what's your thoughts regarding the use of abdominal ultrasound to look at Doppler changes or pneumatosis for earlier diagnosis of NEC in general, and maybe specifically in this population, if you can comment on that tool?
Okay, thanks, Ravi. So let me talk about first kind of what's relevant to what we do. So we routinely will assess flow in the celiac artery and the SMA, just a conventional Doppler, more so to adjudicate shunt, is the shunt bad, or two, if there's a low cardiac output state from heart dysfunction, is there bowel perfusion? That's kind of a step A, which is more of a kind of how do we optimize flow and prevent NEC happening. With respect to the second part, in terms of the more global use of ultrasound for early diagnosis of NEC, that I know is a complete minefield. When I was at Sick Kids, this would have been routinely used to kind of assess for early NEC. I think the bottom line is it depends on the operator. It depends on the skill of the person, the volume of assessments that they do. I think it's the type of thing that should not be used ubiquitously by many, many people. Same reason why within our concept of neonatal hemodynamics, you want to focus on a small core group of people doing these evaluations rather than everybody doing it. If everybody does it, nobody is good at it. So I think it probably does have a role. I would be very interested to look and perform a correlative study between Doppler changes and more microperfusion of the bowel. So these infants that have, say, flow reversal in the SMA or celiac artery, to actually look then at a bowel perfusion level itself, what is the impact and how does feeding change? But I think with anything, you saw my tale of caution. SMA in the wrong hands, you can make it look abnormal. And I think it's really important that the skill level of the person, that needs to be paramount.
Okay. And when you're looking at this specific, there's a question about looking at SMA. Is that the primary vascular bed that you're interested in when you're looking at flow, or the other areas?
Well, so we look at both SMA and celiac, and the reason we look at both, obviously part of your bowel requires a celiac artery as well, but the celiac artery kind of, the picture I had, you could see that it aligns very nicely with your Doppler cursor. The SMA has got the angle at which you try to interrogate it is not a perfect. You should be looking at these vessels in a direction that is parallel to the direction of flow. More difficult to do with the SMA, not impossible. Okay, I think within skilled hands you can do it properly, but I have a kind of a cautious skepticism about, in all of the research published to date, have people done things with a degree of precision, just like why we say PDA diameter is highly unreliable. It's something in the wrong hands. I can make it look small or I can make it look big, and that's why a more comprehensive approach is really the only way to understand things. So I think we need more bowel perfusion studies specific to specific conditions, but I think we need to make sure that the people using these techniques use them correctly.
Thanks, Patrick. This is a question, and maybe I can direct this to Caitlin, about, you spoke a lot about kind of left-sided obstructive lesions and lesions where there might not be enough flow, but I wonder if you could comment about lesions where there's enough blood flow to the gut, but in cyanotic disease where infants are living at lower oxygen saturations and kind of that risk, and how it might be different than the obstructive cardiac lesion.
Yeah, so it's a great question, and I think to begin with, it involves actually sort of defining what we mean by a cyanotic heart lesion. So I did speak quite a lot about mixing lesions, and even though those patients typically have higher saturations, by definition they are a cyanotic lesion, because the definition of cyanotic heart lesion means a lesion by which the deoxyhemoglobin can freely get out in systemic circulation. And so mixing lesions as a bucket, when you've got all your deoxy blood and all your oxygenated blood mixing together, you will have deoxyhemoglobin out into your systemic circulation. So mixing lesions, which we spent a good deal of time talking about, are a type of cyanotic heart lesion. So I did want to emphasize that, even if they don't visibly appear cyanotic. The question of patients with lower saturations and what sort of risk they would be at. Well, it sort of goes down, it sort of distills down to, what are we talking about when we're talking about blood flow to the gut? What we're talking about is oxygen delivery to the gut. And when you've got less volume, even if the sats are good, you can have the sort of ischemic damage to the gut. The same thing goes if you have lots of volume, but very, very poor delivery, because you are so cyanotic, because your sats are so low, there would also be risk for those patients. So it depends on exactly what the reason that the oxygen delivery to the gut is, but our extremely cyanotic patients would be at risk as well, because the issue is ischemia or poor delivery to the gut. The other thing to just mention is that even if a patient has a cyanotic heart lesion where their sats are not particularly low, but they're palliated in such a way that they're at risk for diastolic flow reversal in the aorta. So some of our single ventricles with BTT shunt, or our pulmonary atresia, or versions of TETs with extremely severe right ventricular outflow tract obstruction. If they're palliated with a BTT shunt, we're essentially creating a surgical aortic to pulmonary communication, just like a ductus. And so those patients remain at risk as well, even if their sats are okay, because of some of the things we have to do for them. So, again, there are lots of risks in lots of different ways for our heart babies.
Thank you. Amy, there's several questions here on feeding, which I think you touched on, but one of the questions that you highlighted at the end was, a lot of these infants who have cardiac lesions need a much higher caloric intake, and maybe how you achieve that, currently with breast milk, and then also tied to that, maybe the use of partially hydrolyzed or complete amino acid formula in infants if breast milk's not available.
Right, thank you. No, I mean, I realize I've been looking at all these questions, a lot of them are nutrition. I could have given this talk in 2 hours, so I apologize to the group if I left things out. Let's see, a couple things. One, I wanted to point out our study that looked at preoperative feeding. We found if babies were receiving a volume more than 100 mLs per kilo per day, if they were on more than that volume, they had a higher increase of NEC. So at our institution, we generally top out at 60 mLs per kilo per day when they're on prostaglandins. So they have a ductal dependent lesion, and sometimes we just trickle feed, so like 20 mLs per kilo per day. So I think any type of feeding is better than none. Speaking to Ravi's question, if you don't, I know some places don't have donor milk, or they don't have donor milk available in the way that they can use it for term kids. I mean, these term babies with cardiac disease are larger than our little 500 grammers in the NICU. There's not a lot of research. I mean, we could extrapolate something from the preemie world. I mean, I'll just give, this is personal, I'm not giving medical advice, but I also take care of babies with ultra short gut and intestinal failure. And so we usually default to an elemental formula or something partially hydrolyzed. But I think it just depends what the practice is in your unit. But I guess being able to take care of a baby that had NEC that only has 10 centimeters of bowel left, and we've had some cardiac kids like that, an elemental formula has served as a good backup if we don't have breast milk. And then talking about calories, well, these are term babies, but they are often volume restricted and they need a lot of calories. So you do need to add quite amount. So generally we use formula. There is the bovine hydrolyzed HMF we use in preemies. That's generally not good for cardiac babies because it has too many minerals like calcium, phosphorus, and vitamins for the term babies. So we will do breast milk with, adding the addition of this formula. And then, as I mentioned, there are some products coming out. I know there's a formula that's partially hydrolyzed. It's 30 calories per ounce, meant for the cardiac population. And we're doing a fortifier study looking at a different way to fit calories safely and not having to use formula.
Thanks, Amy. And Steve, one of the questions here is about kind of antenatal testing and findings in these infants, and if you find, for example, absent or reversed umbilical artery flow detected antenatally, how you might approach feeding. And tied to that, do we know anything about maybe the in utero kind of effects of cardiac disease on the gut and how it develops?
So those are awesome questions. And I was just thinking as we've been answering these questions, the real answer to most of this is we don't know. Just because as I said in that first section, we really have only recognized this as a separate entity probably in the last 10 years, which that seems like a long time, but in the research world, that's really not that long. I have no idea of any data that looks at prenatal diagnosis of heart disease and what happens afterwards as far as feeding. And as far as looking at blood flow in these kids and how we should go about feeding them, again, across neonatology, I mean, we've got what, 1, 2, 3, there's 3, 4 neonatologists on this panel. We probably would all have different opinions on how to do different things. Feeding is not very standardized, even in the neonatal world. And then when you go out of the NICUs and into the PICUs, which is a different subset where most of these cardiac kids are, it's completely unknown. And so I would love to have a better answer, but I think we just don't know. I think that, when we first started talking about cardiac NEC as a thing in the NEC Society, and that was probably, 2 years ago, I think, there was just nothing. I mean, we kind of looked at this and said, we know nothing in the literature. There's not that much information out there. Where do we even start? And I think things like this are the first step, because it allows us to start having the conversation and seeing what gaps there are so we can start trying to address them. And I think that's a bad answer, but that's the only one we currently have.
Thanks, Stephen. A couple more questions about feeding and nutritional supplementation. So one is, as the panelists, if you have any thoughts on the use of probiotics in children with congenital heart disease. And I know it's used in the preterm population, but in this specific term population, I wonder, Caitlin, if you use it at your center, any thoughts, and then maybe the other panelists.
Yeah, we definitely do not use it in our cardiac babies. Part of it has to do with the fact that, unlike NICU babies where the primary issue is the prematurity, most of our kids, if they're sick enough to be in the hospital as a neonate, they are sort of perioperative. They're either going to surgery, they're about to go to surgery. So there's sort of input from the CT surgeons, and a lot of times they don't like the idea of having anything sort of on board that might be a probiotic, even though, you would say, well, shouldn't that prevent infection? There remains to be some hesitancy. What I would say is and also from my understanding, there is sort of, there are varying opinions even within the NICU community of whether they truly are an effective treatment. But what I would say is that even without considering probiotics, it's amazing what is done widely in the neonatology community that the cardiac community has not yet embraced. And so Amy really touched on this with, it's standard of care in NICU to be promoting mother's milk, to be giving donor breast milk, to be, limiting antacids. And those things are just not discussed in most cardiac units. And so rather than sort of picking something that's a bit more experimental, at least in my home institution, I've really been a proponent of things that have been proven and well vetted and accepted within the neonatology community as things that have been proven to decrease NEC rates, and really starting with milk and limitation of antacids.
Yeah, Ravi, I was going to say, Caitlin, amazing answer. I echo that. I believe there's one study in the past year it's talking about the use of probiotics in feeds, and I don't want to misquote the study because I can't remember all the details, but I think it was positive regarding the use of probiotics. So there's one paper out there.
The other thing I was just going to add quick, it depends on what the probiotic's doing, right? So the probiotics work by specific functions. If they're working to, say, shore up the tight junctions, then they may have less effect than if they're impacting the immune system. And that's kind of the tricky thing with this is we don't know, we're not clear totally on which probiotics are doing what. And since cardiac NEC seems to be a different physiology than preemie NEC, I think that needs to be vetted a little bit before we get too ahead of ourselves.
Can I make a comment about something else? I just want to set it in people's mind. We've had this conversation for the last hour and a half on the basis that we believe hypoxia and ischemia is the problem. What we've not talked about, and no one has talked about, is reperfusion. And that's a concept that I think is incredibly important. One of the things that's always intrigued me, both when I was in sick kids and thinking we would have kind of our asphyxia patient population, we cooled 80 to 90 babies a year over 10 years. I never saw NEC, okay? And that always intrigued me. And, you know, again, just to set that seed there, how much of it is optimization of the delivery versus preventing reperfusion injury. So I don't have an answer, but again, this is why we have these conversations.
And Patrick, do you know if there's any types of markers that might differentiate those two? And we had a question about biomarkers. If you know of anything that investigation.
I'm not sure, Ravi. I think that the problem is trying to identify when there is reperfusion. Now, the only thing is going back to that very, very old study by Stephen Pendle, kind of, which showed that the babies who got bad NEC and died had it before their duct was closed, and that problem didn't seem to happen afterwards. So that might suggest that, at least in that context, that kind of the reperfusion wasn't causing harm. But I don't know that with respect to other situations, kind of, you know, kind of the post-op cardiac patients, you know, what is it? Is it duration of exposure to hypoxia ischemia, or is it that plus being reperfused?
Mm-hmm.
Yeah.
And we've had a couple of questions, one in the chat, another one about the use of NERS and kind of how that might be used to assess the adequacy of oxygen delivery and perfusion. And Patrick, I wonder if you wanted to touch on that, and maybe Caitlin as well, about whether you use NERS routinely and how that's adjunctive to some of the echocardiographic data that you obtain.
Like I'm only aware of that one study that was done by Frank Van Bel's group in Belgium, where they basically looked at a cohort of babies who had PDA shunts versus no PDA shunts, and basically showed impaired oxygenation, and that impaired oxygenation recovered following closure of the vessel. Just like when we close the PDA, you see recovery of the diastolic flow. Outside of that, I've not seen anything. But again, I think it's I think in centers where perhaps you can't do very comprehensive assessment, it may be an adjunct to selecting patients for intervention.
Yeah, so I'm also only aware of one study looking at use of NERS in congenital heart disease, specifically single ventricle as well as biventricular repair. This was published in Pediatric Cardiology back in 2014, DeWitt et al. And it was looking at babies at University of Michigan who went on to develop NEC following their surgical repairs. And what it did show is that those with proven NEC, so Bell's stage 2 or above, did have lower splanchnic NERS than those without proven NEC. I would say, despite the fact that that study was published, it is not a widely done practice. We do not do it at my institution in our CPICU, but there is some suggestion that if done, done well, there may be some benefit there, or there may be some ability to predict risk for death.
And I think we'll finish on maybe a couple of questions regarding how we feed and the use of continuous versus bolus feeding, and also the use of NJ feeding in this population, and lots of interest in the area. So Amy, I wonder if you could give us your thoughts on that.
Yeah, I think I'll start, and then Caitlin can finish, because she does a lot of post-operative. So, I mean, from the preemie world and physiology-wise, every 3 hours are bolus feeds, and we even do this in our short bowel syndrome babies. I mean, that's physiologic. We personally use continuous feeds as a second line. So I would say, I believe our cardiac ICU, we do start with oral, preferably oral over tube feeds, and then try bolus, then move to continuous. The NJ tube, I have to leave to Caitlin, because for us in the NICU, we use that last line. I know that they tend to use it more sooner in the cardiac ICU, especially if the baby's intubated and they want to feed. But yeah, and one other thing to remind you guys is if you're using primarily human milk, even if you're adding formula to it, if you run feeds continuously, you are going to lose 40% breast milk fat, which provides the most calories to the baby. So just to know that you're losing 40% of your fat calories if you do continuous. So just another thing. And then Caitlin, did you want to talk about the NJ feeds?
Yeah, I mean, I would say our use of NJ is mostly dictated by what other issues are going on with the baby. So usually if there's respiratory or there's concern that they're at an aspiration risk, that's usually when we end up using NJ feeds versus NG or oral.
Thank you so much to all of you for presenting. I think and to all of those that attended for all the questions. I'm sorry we didn't get a chance to get through all of them, but I'm glad we had a chance and a good discussion here. I'll turn it back over to Jonathan and Jen.
Awesome. Thanks so much, everyone. Thank you to our amazing presenters and to Ravi for moderating. Thank you all to all of our participants. And we look forward to seeing you on our next webinar where we'll talk about the long-term outcomes of NEC. So we'll see you again. And just a friendly reminder to please vote on or before November 3rd if you can. So thanks, everybody. Take care.